Hello and welcome once again to Krok 2 2023 booklet. This was done on May 23rd, and today we are going through the second presentation of this booklet. If you are new on my channel, kindly subscribe for more. If you're already a subscriber, thank you for coming back again. Now, let's begin. So a 6-year-old child became acutely ill and developed fever, headache, and pain during swallowing. It simply means there is definitely a throat infection, normally caused by strep. Now, 3 hours later, a bright red fine pointed rash appeared on a hyperemic skin. That means the skin has become reddish. Now, the rash is more numerous on the lateral surfaces of the body and in the natural folds. Oropharyngeal mucosa has a clearly demarcated hyperemia, and there is a purulent plaque on the tonsils. Again, it means there is some form of throat infection, likely tonsillitis. So what disease can be suspected in the child? This is definitely a case of scarlet fever, which develops in some people who have throat or strep throat, So this is what it means to have a tonsillitis or to have a strep throat. So this thing over here, you can see there is what we call a demarcated hyperemia with some purulent plaques in the tonsils. So that is why this right side is tonsillitis or is abnormal. And look at the other side, very normal tonsils. But over here, the other side, we are having some plaques in the tonsils, and that is why we say this is a strep throat or a tonsillitis. And we are saying that in scarlet fever, it develops when people have had or people are having a strep throat. Normally, people with strep throat or people with scarlet fever, you will see a bright red rash that covers most of the body. The rash normally looks like a sunburn, and it feels like a sandpaper. I always tell people who really appreciate this, just go to the chemistry shop, ask them for a sandpaper. All right, you see how rough it is. So that is how it feels like when you see a scarlet fever. Typically, it can start from the face or start on the face, go to the neck, it will spread to the trunk, the arms, and the legs. Now, when you push these rashes, what happens is that it turns pale or it becomes pale. So when you press on the reddened skin, it becomes pale. Now, the folds of the skin around the groin, the armpit, the elbow, the knee, and then the neck usually become a deeper red than the other areas with the rash. Sometimes there may also be the presence of a strawberry tongue, where the tongue generally looks red and pumpy and often covered with a white coating early in the disease. Normally, it comes with, again, throat infection with a high fever and common in children between the ages of 5 to 50 years. All right. Now, this is a case of what we call infectious mononucleosis. So you don't confuse scarlet fever with diphtheria, infectious mononucleosis, and the rest. So I want to just elaborate a little bit on it. So now, normally or usually, diphtheria and infectious mononucleosis are misdiagnosed. So anytime you have a swollen tonsils that appear red and with white lesions that may be oozing pus, then you are actually looking at infectious mononucleosis. It's caused by EBV or Epstein-Barr virus. Now, EBV or this Epstein-Barr virus skin also has some rash, but this rash normally will appear after an exposure to antimicrobials, even though sometimes It can appear even in the absence of antimicrobials. Again, in mononucleosis, it will spread through the saliva, and therefore sometimes we call it the kissing disease. The kissing disease. Sometimes the liver, the spleen may all become swollen, and less than 1% of the cases you can see splenic rupture. Less than 1% of the cases. So that is for infectious mononucleosis. Now, anytime you also see gray-white pellicles which cannot be easily removed. So look at this over here. This is a pellicle. It cannot be easily removed. If you see something like that, then definitely you are looking at diphtheria. You are looking at diphtheria. Of course, it is caused by Corynebacterium diphtheria. It produces a toxin, or it produces a poison, and this can be very contagious. It can be very contagious, and of course life-threatening as well. So that's how diphtheria looks like. That's how diphtheria looks like. And for the others, I just brought this diagram to show you the differentials. You can see what we call varicella, scarlet fever, rubella, and the measles. How do we differentiate between all of these things? Now, when we talk about varicella, we're simply referring to chickenpox. And the classic symptom of chickenpox is a rash that turns into itchy, fluid-filled blisters that eventually turn into scabs. All right, so the rash may first show up on the chest, the back, the face, and then to spread all over the entire body, even including the mouth, the eyelids, and even the genital areas. So that is varicella. We also have to call the rubella, also known as the German measles, or a 3-day measles. This is normally a fine by spotty pink rash that appear on the face, the trunk, and then the arms and the legs. So that is what rubella. And then we now have the original measles, or what we call the measles. Very contagious, can cause fever, red rash, cough, and watery eyes. We normally use some 3 C's to identify what we call measles, but basically we are referring to the cough, the coryza or the watery eyes, and then the the red rash, and all of those things. Together we have what we call the measles. So these are just the differential diagnosis to scarlet fever. So over here, definitely our answer is what? Is A, scarlet fever. Now we have a person who has been hospitalized with the diagnosis of trichinosis. What food product is the likely cause of this epilepticus? What food product? Now this trichinosis is also called trichinosis. I prefer calling that one trichinosis. It's a disease that people can get by eating raw or undercooked meat from animals, especially pork infected with what we call trichinella. All right. Now, other animals that can be affected include the bears, the foxes, the wild boars, the domestic pigs, and so on and so forth. All right. So this is just a typical representation of the life cycle of the trichinosis, or how it happens. So this is how it happens. All right. So normally the host can be a rodent. All right. Then we can also have what's called the transient host, which is the pig. Then inside the pig we can have the larva in the skeletal muscle. So those who like pork, that is it. Then we eat it. If it is undercooked or it is poorly cooked, we ingest it into our system, which would then travel into the small intestine where they mature and reproduce. They will mature and reproduce, and then we start having those infections. So unfortunately, the answer is already here, but the answer is definitely pork. Pork. So your answer is A. Now we have a 65-year-old woman who came to a hospital to a doctor with complaints of weakness in her left limbs. The weakness appeared in the morning and was gradually increasing throughout the day. Objectively, her consciousness is clear, but her blood pressure is 190/100. This is typically high. Her heart rate is within normal. 80 is rhythmic. Systolic murmur can be detected on the neck in the projection of the bifurcation of the right common carotid artery. Again, the heart is a problem one way or the other. There's a problem with the heart as well. And if you have high blood pressure, heart can be a target. Now, examination of the neurological status detects a smoothed out nasolabial fold on the left, a deviation of the tongue to the left, a decrease in the muscle strength of the left limbs to 3 point. Tendon reflexes, the Babinski sign, positive, left-sided hemiparesis is observed. What is the most likely diagnosis? Even without going through it, definitely you will know that it's a problem of the brain. This is a problem of the brain. But before we arrive at our answer, let's quickly go through some few things so that it can help us with our diagnosis. So normally when we say weakness simply refers to loss of muscle strength. So if you are in your final year, which you are now, you go to the hospital, say check the power. They will say 1/5, 2/5, or 5/5. If everything is all right, you say 5/5. You check it about what? The power. So when we refer to weakness, we're referring to what? Loss of muscle strength. That is, people cannot move a muscle normally despite trying as hard as they can. However, the term is often misused. So for a person to intentionally move a muscle, we call it voluntary movement or voluntary muscle contraction, the brain must generate a signal. So that's why I bring this diagram over here. The brain must generate a signal that will have to pass through the brainstem into the spinal cord and then into the muscles, and then into the muscles basically. So that is the connection. So it's from the brain to the spinal cord and then to the muscles for contractions to take place. Basically, that's how it works. So therefore, when they say there's a true weakness, what it simply means is that one or more parts of this pathway, which is either the brain, the spinal cord, the nerve, the muscles, or the connections between them, is damaged or diseased. And hence, if they said there's weakness in the limbs, there's facial deviation, you are simply looking at for a brain dysfunction, which could be caused by either cardiovascular accident, by either head injury, by encephalopathy, or any other thing that has to do with the brain. Now, with the question over here, we are looking at the potential risk factor that can change everything. And that potential risk factor here is the blood pressure, which is circled. Is the blood pressure here. So the risk factor here is what? Is the blood pressure. And hence, you can either be looking at a case of what? Acute hypertensive encephalopathy or a cardiovascular accident, which is popularly known as stroke. We call it what? Stroke. Now, the symptoms of hypertensive encephalopathy are normally gradual. So the headache, the nausea, the vomiting gradually worsen with time, and then are now followed by non-localizing neurologic symptoms. Again, non-localizing, then you cannot pinpoint exactly where the problem is coming from, but generally you realize that neurologically the person is not well. But in this question, you can see that there is exactly where the problems are, isn't it? And that makes me to define what cardiovascular accident could mean or is. So in stroke, there is a sudden or there is a focal neurologic symptom that is found either with ischemic stroke or intracerebral hemorrhage. Ischemic stroke or intracerebral hemorrhage. And that brings me to this particular diagram where we have the different types of stroke. We have the ischemic, which means there's reduced blood flow. We have hemorrhagic, which means there is an injury or there's a bleeding in the brain, or we have what we call the transient ischemic attack, which means it's a form of stroke, but it is temporal. So it can reverse, it can easily be reversed. That's called TIA or transient ischemic stroke. Now, from the diagram or from this question, there is no history, all right, of trauma, which means that I can easily rule out hemorrhagic stroke. Of course, we have already ruled out hypertensive encephalopathy, isn't it? So now I can also easily rule out hemorrhagic stroke. That leaves me with ischemic stroke. But ideally, a CT scan should be provided. So a CT scan will help you to know whether you are dealing with an ischemic stroke or a hemorrhagic stroke. But since there's no CT, then we use the the history to tell. And that is over here. You are looking at B as your answer, ischemic stroke. Now, a 45-year-old man came to a doctor complaining of a sore throat and a fever that lasts for 10 days. 10 good days. Now, the patient has a history of ulcerative colitis. Patient is a smoker, has been smoking 1 pack of cigarette per day for 10 years. Patient's father died of cancer of the large intestine at the age of 50. Anytime they tell you this, is to tell you that this patient could be having a similar episode. That is why family history is always very important for us if we are going to make a diagnosis. So over here, as a doctor, you're already thinking about something relating to or related to his father's death, which could have been a cancer from his habit, the chronic smoking and colitis and all those sort of stuff. Physical examination shows the following. There's a body temperature, 38. There's fever, there's pressure. It's within, though it's not very normal, but it is within normal range. The pulse 72, respiratory rate is 18. Examination of the oral cavity reveals erythematous pharynx and exudate in the tonsillar crypts. Antigen test for a group A streptococcal was positive. Again, you already know it. Tonsillitis in a way from the throat, isn't it? What procedure that doctor can recommend for secondary prevention of cancer? So in all of this talking, they're asking you secondary prevention of what cancer? How do we prevent cancer? So first of all, to prevent it, you have to, one or the other, test for its presence, isn't it? Test for its presence. That's why you have to do what to call a biopsy. So for every malignancy, biopsy is needed. And hence, in this particular patient, either you are doing a sigmoidoscopy or a colonoscopy. Again, either you are focusing on the sigmoid or the whole colon. Either the sigmoid or the whole colon. So this is just to show you the various kind of biopsies: excision biopsy, sentinel node biopsy, needle biopsy, bone marrow biopsy. Depending on what you're looking at, you know which kind of biopsy to take. All right. Now over here, we are going to definitely be looking at a colonoscopy. And I'll tell you why in a jiffy. Now, Sigmoidoscopy, again, is normally different from colonoscopy because sigmoid will only target only the rectum and the lower part of the bowel. Only the rectum, or it will check inside the rectum or the lower part of the bowel. Whereas colonoscopy will look at the entire bowel. Yes, from the question over here, normally colitis and stuff like that, you're looking at the sigmoid, basically. That's what you're looking at. However, again, you are going to look for what's called secondary prevention. So you want to scan through the entire colon. You want to check the entire colon to know what is happening. And that is why we are going to go in for a colonoscopy. So this is it. This black something there. See, it passes through the whole colon to check for any presence of node, any presence of tumor, what have you. So that will help us to know what is happening and then to see how best we can prevent this patient from developing cancer. So that's over here. Your answer will be E, colonoscopy. A patient with epilepsy suddenly developed status epilepticus with generalized seizures after self-discontinuation of anti-epileptic drugs. So again, patient knows that he's epileptic but refused the medication. So now we're in crisis. Now we have what? Status epilepticus. We're in crisis now. So what is the first line of drugs for the treatment of this condition? So what is status epilepticus? It can be defined as a critical medical emergency that is identified by prolonged or repetitive seizures that last for more than 5 minutes or by multiple seizures without complete recovery of consciousness in the intervening period. That's what it means by status epilepticus. All right. So how do we manage such cases when they come to us? So normally the thing to do first is to stop the seizure. And how do you do that? You give your IV medications and then make sure the patient is safe from convulsing trauma. Sometimes you check the surrounding to make sure that there's nothing there that can harm the patient. All right. But what's the first line of treatment? Normally we do what we call, or we give diazepam. Then we move to lorazepam, and so on and so forth. So that's over here. Our best answer will be what? E. Diazepam, lorazepam, midazolam. So your answer here is E. A 38-year-old pregnant woman, gravida 2, gestation time of 23 to 24 weeks, type 2 diabetes, for which she receives metformin 2.5 grams or 2,500 milligrams per 24 hours. HbA1c shows 7.2. What further treatment strategy should be chosen for this patient? Normally, what we use to confirm that the diabetes is what we call the HbA1c. Normally, it should be less than 6.4. Some books say, others say 6.4. All right, so over here, they say 6.4, isn't it? But regardless, it is still high. Normally, if you have diabetes and you're being on a treatment, we're expecting to get an HbA1c of 7 or less. 7 or less. If it's more than that, it means it is poorly controlled. So what it means in this patient is that the sugar levels are poorly controlled. Even though it is good, but it can be better, isn't it? So you just have to increase the dose of the metformin and patient will definitely be fine. And that's why over here, your answer is A. You increase it to 3,000 and patient will be very okay. The answer is A. It was found that for every 100 births, women with risk factors had risk of 30 preterm birth. So when they take in the whole population, they are taking just 100 birth. But you and I know that in a population, there can be more than 100 birth, isn't it? So this, we call it sample. So they're just taking a sample of the population, just a sample, just to make a point, just a sample. So again, they've taken just 100 birth out of the total population, and they are saying that women with risk factors for getting preterm birth is 30, while women without risk factors had 5 preterm birth. All right. What statistical method of data processing would be optimal for a doctor to use to estimate the validity of differences between the groups that are being compared? This is a question that confuses a lot of people. All right. It confuses me too. All right. But we'll find explanation to it. All right. So over here, they are either looking for what we call standard deviation or what we call T distribution or student T distribution. Exactly. So I'll just take bit by bit and I'll explain to you. So this is a standard deviation. All right. When we talk about standard deviation, we're referring to a number that is used to tell how dispersed a data is to the mean value. I repeat, it is used to determine how a data is dispersed to a mean value. Now I've put some values over here: 76, 84, 69, 92, 58, blah 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 blah. Now let's calculate the mean. To calculate the mean, let's assume that this is a test score, for example. This is a test score. In our class, we have a lot of students in the class, all right? But now I want to look at the average score. The average score. So you add all their marks by the total number of people in class. So over here we have 1, 2, 3, 4, 1, 2, 3, 4, 5. This is 10. This is 10 students in the class. Out of the 10 students, some are getting 76, 84, 69, 92, 58, blah, 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 blah. So you add all these values and you divide it by 10. That is called the mean. That is called the mean. Now, so let's say the mean, at the end of the day, the mean is, let's just say the mean is equal to 60. I've not done a calculation, I don't know. So you can do a calculation. Let's assume the mean is 16. When we talk about standard deviation, we're referring to, now look at it, 76 is further away from 60. 84 is even more further, or it's further. It's far away. 69 is closer to 60. 92 is very far. 58 is very close to 60. 89 is far away. 73, 97 in that way. So when we say standard deviation, we're referring to how dispersed individual marks are away from the mean mark. How individual marks are far away from the mean mark. And I've already calculated the mean for you. The sum of the numbers or the values divided by the total number of people, or the total number of people. So now if you have a low standard deviation, it means that most of the numbers are close to the average. That's what I say over here. I can say 69 is close to the average is 60, and then 58 is close. So if more are closer to 80, it means that we have low standard deviation. While a high standard deviation means that the numbers are more spread out, or they are very dispersed from the mean or from the average number. So that is what it's all about. So this diagram shows a standard deviation of a normal distribution. Standard deviation. So the middle one here, the middle here is the mean. Middle line here is the mean. All right. So that's just how it is. Middle here is the mean. Then as you move away, So 20 is far away from the mean. Now I said the mean here is what is 50. So 20 is far away. 30 is closer, even though it's also far. 40 is much closer. 60 is so closer. 70 is further away. 80 is even more further away, isn't it? That is what it means by standard uh, deviation. Standard deviation. Now, at what point are you going to say you are dealing with standard deviation, and at what point? So let me bring another diagram that shows the t distribution. So this is the t distribution, okay? Of course, the one here, or the z distribution, simply refers to the standard or the normal deviation. Standard or normal deviation. Then look at it. As the number gets smaller than 30, look at it. The distance goes down. If you close to 30, it comes to the middle. And that brings me to a point I would like to illustrate for you. Now, if the sample size, if the n under discussion, or the sample size, or the size of the population under discussion, if it is a sample representing the whole, then we are using the t distribution or the student distribution. Again, if we are getting a sample from a total, like I said, in a community, I'm sure the community, there are more than 100 people in the community, or more than 100 births in that particular community. Let's say Ghana, for instance, or let me use Ukraine since we are doing Krok. Take Ukraine, let's take Kiev, for instance, or the whole country as an example. Definitely, we have a lot of people giving birth, right? We have a lot of people giving birth. But out of those plenty people, we have just chosen 100 births, which means that this is just a sample to represent the total. So it is not the whole total, it is not the actual total in question or the actual number of births in that particular region or in that particular country. It is not. It is just a sample. We are assuming if we take 100 people, so that informs you that no, you're going to be dealing with what? A t distribution. However, if the population or if the sample space is the exact population, then we are using what we call the standard deviation. We use what we call the standard deviation. And again, if n or the population under discussion is less than 30, then we are dealing with the t distribution. And if it is more than 30 or more, then you are dealing with what? Standard deviation or standardization method. And that is why I'm going to make this statement to you, and I hope that you will write it nicely in your book. So now we see that the t distribution or the student distribution, it is used to estimate population parameters when the sample size is small. When I say small, less than 30, and or when the population variance is unknown. In other words, we are not too sure of the total number of people. Then again, we are using the student's distribution or the t distribution. Or the t distribution. And that's over here. We will be dealing with what we call student's distribution or the student's criterion. All right. I know it's a whole lot to comprehend. You can just pause the video, reverse it, and watch it over and over again. And I'm sure it will make sense. So, with apply this principle, again, we are doing the sample space. If it's a sample representing the whole, again, t distribution. If the population size is not known, again, t distribution. All right. Now we have a 36-year-old patient complaining of suffocation attacks with predominantly problematic exhalation. So that means that Person can actually breathe in, but bringing out is a problem. So it's an obstruction, isn't it? It's an obstruction. It's an obstruction. The attacks occur up to 2 to 3 times a day and can be relieved by inhalation of beta-2 adrenomimetics. Beta-2 adrenomimetics. And when we talk about beta-2, an example is the salbutamol. So when I say salbutamol, definitely you know you're dealing with asthma or constricted bronchi or bronchus. Now, this condition lasts for 10 years already. The chest is expanded. Percussion notice detects a bandbox that is air. Auscultation detects harsh respiration with prolonged exhalation. Then we can't get the air out of the lungs. Lab analysis shows numerous eosinophils, Charcot-Leyden crystals, Cushman's spirals. What is the provisional diagnosis in this case? So this is what they're looking at. So this is simply an asthmatic attack, all right? So where your bronchi begin to get inflamed and all that, and then making it difficult to breathe out. Making it difficult to breathe out. And when you look at the cells or the histology of the asthma or the morphology in asthma, you're looking at what we call the Kussmaul's spirals and the Charcot-Leyden crystals. This refers to, or the Kussmaul's spiral refers to well basophilic plaques of mucus formed in the lower airways and are found in the sputum and the tracheal washings, whilst the Charcot-Leyden crystals are eosinophilic needle-shaped crystalline structures. Look at it. So that is that it's definitely a case of what? Asthma. It's a case of asthma. And that's over here. Your answer here is D. Bronchial asthma. Bronchial asthma. So your answer is D. 62-year-old man complains of constant pain in the epigastrium and weight loss of 12 kg. There's weight loss of 12 kg. This is very, very significant. And that tells me, oh, it could be a cancer, right? Or it could be a chronic condition, something chronic or something cancerous. Now, physical and instrumental examinations detected cancer, so they've already told you, or the body of the stomach without signs of distant metastasis. So it's cancer of the stomach, sorry. Cancer of the body of the stomach. So this is of not all. Histology reveals moderately differentiated adenosarcoma. What scope of surgical intervention is advised? So now we've confirmed that there is cancer. We've confirmed that there is cancer. So it's a cancer, what do you do? Luckily for us, there is no metastasis. So you can easily remove it from there. You can easily remove it from there. And that's over here. We're going to talk about what? Gastrectomy. Gastrectomy. A surgical treatment that involves the removal of all or portion of the stomach. All or portion of the stomach. And again, since we have confirmed cancer, that means you are dealing with a biopsy if you want to check the person out or confirm it. It's the same thing. So biopsy. And of course, biopsy has already confirmed that there's what adenosarcoma. All right. So that means you are now confirmed that it is a cancer. So what you have to do is to remove the area which is affected. That is it. Remove the area which is affected. Now, when gastrectomy is performed, a gastric resection is required to reconnect the gastrointestinal tract so that digestion can take place as normally as possible. So if you have cut some part of the, how do you call it, of the stomach, I have to rejoin it. So there's what an anastomosis to rejoin so that everything will continue perfectly. All right. Now we have different types of gastrectomy. We have different types of gastrectomy. All right. And if I put it here, yes. But we have different. So we have the partial, we have the the total, and so on and so forth. We are doing more than that. So talk about the total gastrectomy. We are referring to the whole stomach being removed. Partial means the lower part of the stomach or the antrum is being removed. We have what we call sleeve gastrectomy, where the left side of the stomach is removed. Then we have esophageal gastrectomy. That means part of the, how do you call it? The esophagus will be involved. Part of the esophagus will be involved. So they are all different terms, but in all, it's all called gastrectomy. It's all called gastrectomy. Now again, the question is to tell us which area of the stomach it is found, whether it is found in the fundus, in the body, or left side, right side, antrum, whatever. It didn't tell us. So we also go in with gastrectomy. So you can't say distal, subtotal, or proximal because we're not sure of where exactly the problem is. If the question was specific, then we would have also been specific. But over here, we are going for what? Gastrectomy. General answer. All right. Again, the question didn't tell us specific area where the problem was happening. So we'll go by that. Now we have what? The patient's son has filed a lawsuit after his mother died of breast cancer. So again, there's breast cancer. Due to the fact that in the past he survived a stroke and had diabetes, aggressive cancer therapy was contraindicated for her. So that means that this patient, they didn't do, aggressive cancer treatment because of the history of stroke and diabetes. So it was contraindicated. So she was suffering from severe pain, but the doctors at the outpatient clinic were unable to obtain even 1 milligram of morphine. Normally, people who are like this, you're just going to manage the pain until the time comes for them to pass on. All right, so you give them a lot of pain medication as much as possible to control the pain as well. So what kind of care should have been provided in this case by the primary care doctors to relieve the patient condition? Again, pain medication, knowing the outcome, knowing that definitely it's going to end up in dying and all that, we call it palliative medical care. Palliative medical care. So we all know, it's a matter of when, not if. It's a matter of when are you dying? Maybe next week, maybe next 2 weeks. It's a matter of when. And that is called a palliative medical care. Palliative medical care. Now, if you enjoy my presentation and you are new, kindly subscribe for more. All right. So over here, your answer is A, palliative medical care. That brings us to the end of this presentation. Hope you learned 1 or 2 things. So see you in my next presentation.